I've been involved in antithrombotic therapy for more than half a century, and I've watched the evolution of anticoagulant therapy from the old standard of heparin and warfarin, and I think that the first major breakthrough was the introduction of low molecular weight heparin in the 1980s. This truly changed the way that we manage patients with thrombosis, both acute treatment and also prevention of thrombosis. Subsequently, we developed drugs that target single coagulation factors, and the prototype of that was fondaparinux. I had the pleasure of being involved in the early work with both of these agents, both low molecular heparin and fondaparinux, and they still remain one of the principal ways of treating patients acutely by parenteral administration of anticoagulants. Towards the end of the last century, there was a very important development in antithrombotic therapy. It was based on a much better understanding of coagulation. It was possible to target single coagulation factors. The two main targets are factor 10 and thrombin, both key in the coagulation cascade, and it was possible to synthesize drugs that target both factor 10 and thrombin to inhibit coagulation. Factor 10 is a key coagulation factor, and it's not a surprise that much of the development was targeting activated factor 10. And there are now 4 factor 10 drugs available worldwide: rivaroxaban, apixaban, edoxaban, and betrixaban. The thrombin inhibitor, dabigatran, is also available. This is an effective agent, but the development of thrombin inhibitors was set back by a drug called zymalagatran, an effective anticoagulant thrombin inhibitor, but was associated with hepatic toxicity. And there was a concern that this might be a class effect of thrombin inhibition. As it turns out, that's not the case, and dabigatran is effective and does not have that problem. But I had the pleasure of being involved with the early development of these drugs clinically, and did some of the first dose-finding studies and subsequently the phase 3 trials, particularly with rivaroxaban, demonstrating its effectiveness both in prevention of thrombosis, treatment of thrombosis, and a reduction of stroke and atrial fibrillation. These drugs, in my view, will completely revolutionize the management of patients who require long-term anticoagulation. They are orally active, they do not require anticoagulant monitoring, and have been shown to be effective, and in many cases reduce the risk of major bleeding complications, and in particular reduce the risk of intracranial hemorrhage. So in my view, in this decade, the DOAC drugs is what we're calling them now, direct oral anticoagulants, will be the drug of choice for patients who require long-term anticoagulation.